The closest comparison I can make is to what it must have been like to be in the middle of the London Blitz during World War II. You know, there are people dying literally every time you walk out of the ICU. The projections, just to give you a size of the problem, were that New York was going to need 20,000 ventilators at the peak. We had about 5,000 or 4,000 available to us, and this was such a big disparity that we needed a solution.
As a frontline critical care doctor, I don't want to give up on anyone. If you don't have enough resources, then you say, okay, we will have to figure out a strategy because losing is not an option.
There's a lot of MacGyvering out there, and some of it is doable and some of it is not doable.
Today we are going to talk about how a specific CPAP and a bi-pap machine can be converted into a ventilator. The goal is to save as many lives as you can with the resources that you have.
I kind of felt like when I was watching the movie, Apollo 13.
We have a situation brewing with the carbon dioxide.
That we're confronted with a life-threatening problem. That's COVID.
Those CO2 levels are going to be getting toxic.
Well, I suggest you gentlemen invent a way to put a square peg in a round hole.
And then in front of us, we have a box. And in the box is the bi-pap device. These are very small but powerful devices that are used for patients who have sleep apnea or other respiratory problems at home. My question was, can we use these devices to ventilate patients in the ICU?
We got to find a way to make this fit into the hole for this, using nothing but that.
And so what I really needed was for our team to figure out how to take what we have at Mount Sinai and come out with a solution. They went and they developed a protocol to connect this device to an endotracheal tube using supplies that are commonly found in all respiratory therapy departments around the country.
And you've probably heard of the effort to try and put two patients on one breathing machine at the same time. Very dangerous and not at all something you would want to do without having thought all aspects of it. The innovation that's gone there has made that at least theoretically possible. And of course, that doubles the number of ventilators you have.
Now, the liability issues also in COVID are covered by the changes in the malpractice law, where now the standard is gross negligence. If a conventional ventilator is available, it should be used.
I'm the one who's looking my patients in the eye and telling them that American College of Chest Physicians, American Respiratory Therapy Association, and American Anesthesia Association has said we can't do this, so goodbye. And I can't do that. What I would do is I'll say, look, I have this experimental option, and this is the last resort. This is not my first choice. I actually want to show you how you can actually use one ventilator to actually give breathing capacity and help to not one, not two, not three, not four, not five, but actually 7 people. So this one outlet is equal to 4, and then 5, 6, 7 patients are connected to this.
Putting 7 patients on a ventilator sounds great. There are physiologic problems, but there are other much simpler problems. How do you move 7 patients? How do you get 7 beds close enough together? 2 is already overwhelming.
Really, that splitting protocol, we would think would only be entertained in the setting where there are no conventional ventilators, no home devices that can be used, and then one might entertain a split ventilator protocol.
The 3D machines that we have are used to make toys. We design and make prototype of our toys. Then we have a factory in Ohio, Little Tikes. We have retooled a portion of Little Tikes factory in Ohio just to make this ventilator mask. We came up with this mask that basically you put over the face of a doctor. It has filters on the top. Then we turn around and made another version for the patient, where you put this on the patient's face, because the ventilators can damage lungs, because that intubation can damage lungs. So what we have come up with this mask, there is no tube going into the lungs of a patient. And you can force oxygen in her or his lungs, and when the patient breathes out, there is a 100% filter, so that doesn't come out to go to the operation room and infect nurses or doctors.
Right now at Mount Sinai, we have more than enough conventional ventilators. We've already hit our peak.
At our end, we're starting to think about the obvious but forgotten problem, which is what happens in Africa, in India, in places like the Caribbean and in the South Pacific, where an entire country may have 1 or 2 ventilators. So we're thinking and trying to work with our colleagues at generalizing this to the point where we can actually package it for them when they get hit 3 or 4 weeks from now, and try and mitigate what is going to be a disaster beyond anybody's perception.
COVID's terrible. I don't need to convince anybody about that, right? And this is something that never should have happened, but there have been some changes that have been made so we could be able to do more with what we have right now. For example, there is now financial coverage for delivering telehealth. This is a program that we're just starting this week, whereby when patients are going to be discharged from our hospital with lung conditions, they're going to be provided with a oximeter. It will flag patients who have a lowering of their oxygen level or change in their condition. And then we contact the patients to follow up. And so these are other examples of innovations that we've been able to now deploy in this setting that are going to have utility in the post-COVID world. And there are times in your life when you just have to give everything you have for as long as you possibly can, because there's so much at stake. And for us in New York, this is that moment.